everyone. This is the first time I've done this, so hopefully everything goes okay. I think we started on time, so that should be pretty good. I am Dr. Shannon Shea of Learn ABA with Dr. Shea, that's me. I have a PhD in Applied Behavior Analysis, a Master of Science in Mental Health Counseling, and a Bachelor's in English. For whatever that's worth, it's less relevant to things. I have a private practice where I see typically developing adults who have, behaviors associated with anxiety, depression, sometimes personality disorders, things like that. I've worked in foster care. I've worked with brain injuries, both traumatic and acquired. I've worked with developmental disabilities throughout the lifespan. I've done end-of-life care. So I've covered like a lot of things in my career. So if you have any questions, there's anything you want me to talk about, just hit it up in the comments, and if I don't see it, maybe say it again, or something like that. I think you can even ask to join on video in this, but I don't know where the button is. But I thought it'd be kind of cool, instead of the Tuesday tip video, to do like office hours, because I'm also a professor, but live here on Facebook. So we'll see how it goes. We'll see who joins. But I think it could be fun, and if this is something that works out well and people like, then we'll do it, maybe every couple of weeks or something like that. So the first thing I wanted to talk about, I wish someone was in here so I'd know if the sound was good, but it should be fine. The first thing I wanted to talk about was really PDA, which is not public displays of affection, but more like a disorder, pathological demand avoidance, which to me is just a name for escape functions. I looked at some of the research on PDA, and I know some people like it. I know that people are finding some value in it. When I read about it, it really goes to me like, what in the name of parsimony is happening here, right? Like, it is just kind of complicating a thing that we already have covered. And I think that we as behavior analysts tend to get in the weeds with diagnoses and with the kind of mental health related stuff, which I've been banging that drum that we should treat that. I first started giving presentations on borderline personality disorder at conferences in like 2014. Like, I've spent 10 years saying we should talk about this, so I'm really happy that everyone's been talking about it, and like, fingers crossed that maybe I had something to do with that. Who knows? But I do think it's an important thing. I think it's a really cool thing that we do that. However, we don't really get too caught up in diagnosis. Like, if someone has PDA versus ODD versus their behaviors that just fall under the umbrella of things for people on the autism spectrum, right? Like, we're still behavior analysts. It shouldn't matter that much, and it's not that important. And I know some of you might get offended, hear me saying it's not that important. However, if you really, really sit down and think about it, like, how does it benefit you or the client? How does it help you identify the function and use antecedent manipulations and write a good treatment plan? Like, what good does it do you knowing a lot about pathological demand avoidance? It's not a neurological disorder. It's not a neurodevelopmental disorder. There's some very early studies, but it's linked with it's always comorbid with other developmental disorders. So I'm tending to think, again, in the name of parsimony, that probably it's not its own thing, but a cluster of behaviors that is recognizable, which is really all everything in the DSM is. Like, the way they come up with the disorders in the DSM, if you guys did not know this, because I do have my master's in counseling, and this was the focus of my PhD, they have committees of psychiatrists, and they say, like, oh, for depression, like, what does that look like? And they discuss what it looks like and research about it. But really, it's a list of behaviors that they notice when they see clients, and they're all displaying similar clumps of behavior, right? So to make it easier to identify, they say, like, well, we're going to name this depression, and if it looks like this, we're going to name this anxiety, so that we have a good way to talk about it, and like a shorthand for what treatments might be effective for things that are similar, because probably similar treatments would work. if that makes sense, which I think it does. But there's not like a blood test, there's not MRIs, there's some fMRIs, but there are some issues with fMRI studies in general. There was a journal article in the Behavior Analyst, which is now Perspectives on Behavioral Science or Behavior Science. I want to say like 10 years ago, and they basically had a dead salmon in the fMRI. And if you run the machine enough times just through static and noise, you can say like, well, I found the dead salmon was thinking with this part of its brain. And like, obviously a dead salmon is not thinking anything. So all these things that we think are very convincing and very like real are not real in the way that diabetes is real, in which I'm saying, what I'm not saying is that mental illness is not real. That is not true at all. Depression is very real. People die from it. Anxiety is very real. All of these things are very real and can ruin people's lives. They're not things that we can look at under a microscope. There's not a blood test for depression. There's not a blood test for anxiety. If they could open up your brain without killing you or damaging your brain and look at your brain, they wouldn't necessarily know which thing you had, even with direct access to your brain, right? So what I'm saying is that, like, you can detect diabetes in a blood test, or I have multiple sclerosis, and you can very clearly see it on MRIs. You can see where the damage is and where there was disease activity, and where that activity happens, I have like a corresponding disability in the part of my body that part of the brain controls, right? So in that, like, it's a thing called multiple sclerosis. This is what it does. This is the effects it has. It's always the same for the most part, depending on where in your brain or spinal cord you get damaged, the signs will show up differently. But generally, it's immune suppressing medication. It's similar to other autoimmune disorders, but they're things that you can get tests for. And if they gave me an autopsy, they would be able to say, like, yes, definitely we confirm 100% instead of just like 99.9% that this person has multiple sclerosis. If you have diabetes, you can get a blood test and learn that you have diabetes, right? That's not true for depression. It's not true for anxiety. It's not true for bipolar disorder. It's not true for borderline personality disorder. And it's certainly not true for PDA, which is a very long-winded way of me saying, even if you can identify PDA, if you're feeling like this is a very important thing suddenly, I would ask, like, what do you get out of that? How is it pragmatic, right? Like, I don't see, I've given the literature on PDA in the past couple of weeks, like an overview and a glance, and I could be wrong. If I'm wrong, please tell me. Like, I want to understand. I don't see how it's helpful to have that diagnosis. And I've seen people in the group commenting, going back and forth and arguing, is it PDA, is it ODD, is it this, is it that? What does it matter in the end? Like, it matters that the person is struggling. It matters that the person is engaging in behaviors that cause them problems, with having meaningful relationships, with accessing life's reinforcers and all of that stuff. That's a big problem that, so I'm not saying that those behaviors are not problematic or they shouldn't be addressed, or like we just leave it alone and everyone's complaining. I'm not saying that at all. I'm saying the concept and the name PDA, for example, or ODD, or any of these like mentalistic constructs that are really what the DSM is comprised of, because they do usually present similarly, people with the same diagnoses. Like, what is that getting you as a behavior analyst? Because I know both. I have my master's degree in counseling. I know the mental health. I had to learn the whole DSM and memorize it and like do diagnostics and diagnose people and take tests on it. And I know ABA very well. Obviously, I'm a BCBAD. I think the real strength to behavior analysis is that we don't get caught up in those things, and that we are so pragmatic and so hands-on. And, if we go back to like Beowulf and Risley and the 7 dimensions, right? Like, even if we think about why we don't use statistics and why we use visual analysis of data and the whole like applied dimension of the 7 dimensions, it's a lot of just, did this make enough difference for me to see it and notice it? Like, I need to see a big change. And if there's not a big change, we don't care. And that's why we don't use statistics. They're used to detect small changes in large data sets that we wouldn't notice if we just looked at it on a graph. And Beowulf and Risley said, like, no, absolutely not. Like if you can't see it easily on a line graph that it was like here and now it's here, if you don't see that big change, we haven't done enough. We haven't done our job, and it's like not even enough of a thing for us to like, we shouldn't be patting ourselves on the back for changes that minor, right? And that's the strength of our field, I think. And that's what makes us different. And that's what makes us able to help a lot of people that are not helped by traditional mental health interventions. So I don't think we should be moving on from that, right? And again, I do both. Like, it's not like I think mental health is nonsense or garbage or anything like that. I teach at a university. I teach psychology courses sometimes. I teach courses about cognition. Like, it's interesting stuff. It's very philosophical. What it isn't is pragmatic. It isn't like a clear path to this is what's causing this behavior and this is what we're going to do now to change that. It's impossible to do that when you're only talking about mentalistic constructs. And if you're just talking about observable, measurable behaviors in operant terms, we don't need to call it anything. We just list the behaviors, right? Because it doesn't matter if someone has PDA or ODD, right? Like say you have two little boys, because it's usually boys that get diagnosed with ODD in my experience. I've never had a girl that got diagnosed with it. Say you have two little boys, they're both 7, one has PDA, one has ODD. They're both engaging in similar behaviors. Like, does it matter to you if it's technically ODD or PDA? Not so much. Now, that being said, because I'm full of nuance, and this is why like Twitter is not for me, because I can't do 1 or 2 sentences. I can barely do the 5 minutes on the Tuesday tips. It's hard for me to keep those short because I have so much information, I think. That being said, there is useful information in these diagnoses. And if someone has a mental or psychiatric diagnosis, we should know that. We should get that as in our background information as part of our functional assessment. And I teach this in the Writing a Great Functional Assessment and Behavior Plan webinar that I do, that people love. Like they ask for it all the time. I should do another live one soon. Anyway, I'm derailing myself and I apologize for that. So what we are going to talk about, like say you have a client that comes to you and they have a diagnosis of, I don't know, like major depressive disorder, or let's say bipolar 1, right? So that's bipolar disorder. 1 means they have hallucinations or delusions. That's the biggest marker between the two. Actually, it's very hard, nearly impossible to tell if someone's in an episode, whether they're schizophrenic or bipolar 1. Bipolar 2 does not have hallucinations or delusions. So there's no psychosis involved in bipolar 2. It's less peaky peaks, but still very deep depression wells. So the suicide rate is roughly the same. They're equally as dangerous as each other, right? So say you have someone with bipolar 1 or bipolar 2, why would you need to know they have that diagnosis? Because am I saying we shouldn't like pay attention to any psychiatric diagnoses and that there's nothing useful to us about that? No, I'm not saying that at all. What I'm saying is if you have someone who's bipolar 1, you should look up that disorder because they have a very, very high suicide rate. So if I have anyone that has major depressive disorder, bipolar disorder, borderline personality disorder, like those 3 have high suicide rates, I'm screening for suicidal ideation and behaviors no matter what. And if when I ask them if they've ever thought of hurting or killing themselves, they're like, "Are you crazy?" and get like really insulted. That's my favorite response because like it sounds like a wild idea that probably they haven't thought of before. But I will screen them for that because since they have these diagnoses, that means they engage in a bunch of behaviors that are listed in the DSM, the psychiatrist or whoever diagnosed them, but someone with at least a master's degree. So not people who have no idea what they're doing. Like someone very educated saw a cluster of behaviors in the DSM and said like, this is what's matching. And I will look at that cluster of behaviors, and if there's something very important that goes along with it, like a suicide risk, I'm going to pay attention to that because that's good holistic treatment, right? Like that's what we're supposed to do. Other things you would want to know, so like bipolar disorder is a good example of this, is that person might have different baselines, right? Like their baseline behavior might change when they're in a psychotic state. You can't really take, I guess you could take a baseline. Bipolar people, most of the time, and the like public at large doesn't know this, which always hits me as strange. Most of the time, people with bipolar disorder are just normal. They're not manic or depressed or in psychosis. It's not manic depression anymore. Although a lot of people with bipolar disorder actually like that term and still use it. But most of the time, they're neither in a manic episode or in a depressive episode. Hopefully, they're probably on meds most of the time, and they're normal, right? They're at baseline. So they might have their baseline, and then they might fall into a depression. And depression can last months and months and months in people with bipolar disorder or people with major depressive disorder. So you might need to do a phase line and a new baseline for when they're in this very different mental state. And that's going to change their responding to stimuli in their environment. It's going to make reinforcers less reinforcing, right? So you're going to have to increase the potency and really beef them up. And you know, if you look in the DSM, that if someone is depressed, that means they are sleeping much more or much less than they used to. They have gained or lost, I believe it's 15% of their overall body weight. So that means they're eating much more, much less than they used to. So if I know someone has a diagnosis of depression or bipolar, am I going to track their sleep and their weight? Yes, because that could give me clues to them starting to get into trouble before I see other things, and then we can make some maybe different environmental modifications for them. Also, if you have someone with any mental health diagnosis, there is a strong possibility that they are on a medicine to help with the diagnosis. So if someone is diagnosed with bipolar disorder, they could have a prescription for like Zyprexa, Seroquel, Latuda are really common. Seroquel makes people so hungry and so tired. People seem to do well. I don't know, like Latuda and Abilify. Anyway, we're not going to get into which meds have the least side effects. We are going to talk about side effects, so that's why I was thinking about that. So the medicines to treat these disorders all have side effects. All of those side effects and the medicine itself, like the purpose of psychiatric medicine is expressly to change your behavior, right? So obviously the medicine that they're on is very important and will impact their behavior. So is your baseline them on medicine? Do you have a pure baseline of them off medicine? If they change medicines, you need a phase line and a new baseline because you want to see what's going on with them, but also you want to provide that information to whoever's prescribing the medicine. And even better than that, go and ask the psychiatrist or the prescribing healthcare provider, what behaviors were you looking to change with this medicine? Like, what do you expect to see? And make sure that those are in your data collection so that you can provide that information to the healthcare provider that you're working with. These are all times it's very useful and very helpful as a behavior analyst to know that someone has a psychiatric diagnosis or that they are working with a mental illness. However, none of those things that I talked about involve us really getting into the nitty-gritties of like diagnosing people or figuring out which diagnosis they have. Because again, like, except in very rare instances, it doesn't really make any difference. And even when it makes a difference, it's not our job to do the diagnosing. Like, we're not trained to diagnose psychiatric disorders or medical problems. Some of you might be trained to do the ADOS for autism screening, but that's kind of it, right? So if you suspect someone has something, your job is to refer them out to someone who treats that, and that would fall under underlying medical conditions, right? So what I'm saying is not that PDA doesn't matter, but I am saying that as BCBAs or behavior analysts in general, we shouldn't get too lost in the weeds of trying to figure out if someone has it or they don't, and like, oh, well, if they have it, then they would be doing this, they're doing this other thing, so it's ODD. It's none of our business to be doing that, but even if it was, like, it doesn't accomplish a lot. And I say this as someone who has fallen into this trap, like, I've done this, so I'm not, like, complaining about any of you or trying to make you feel bad. Like, I myself have fallen into this, and it's why I won't do it anymore. Is you can end up spending like a lot of time and mental resources and energy, you know, like people can get stuck. I've gotten stuck on like, no, this person has this other thing. But then at the end of the day, I've spent all this time like deducing or whatever that I think they have XYZ disorder. If you go back and look, does it change anything in my behavior plan? Usually not, right? Because I knew all their behaviors, right? So if someone was depressed, for example, if I saw someone who was losing weight, who was sleeping a whole lot less, who was talking about death all the time, who was crying for hours for no reason without anything happening, right? They're just sad without an environmental event. I would still think to myself, I should screen this person for suicide risk because, like, they seem like they're struggling, right? So it's very hard for me to think of times when having a diagnosis and confirming it, again, in my role as a behavior analyst, is useful or even like it's a good way to spend a lot of time and you feel like you're accomplishing something. But if you go back and look of like how it actually changed your treatment plan or your assessment or any of that, most of the time it will be and should be that it changed it very, very little. There are some outliers, right? Like Alzheimer's. I've worked with a lot of people like that. That is an important diagnosis, right? Like, but we can use stimulus equivalents still to help them remember some things briefly. But it's a brain damage disorder, right? Their brain is having problems, so we can try to treat issues with Alzheimer's, but we're not going to set goals of like they'll remember 100% of items on a list of 10 items by the end of the month, because that is unrealistic and it's cruel to set goals that people can't achieve, right? You want to make sure things are achievable for people. And sometimes they have sundowning, like people with Alzheimer's, when the sun sets at that time of day, they sometimes tend to have more psychosis, like hallucinations or delusions, and get combative and things like that. So again, with these diagnoses, if someone has one, look up the diagnosis, read about it, because you would want to know, like, oh, if this person has Alzheimer's and they're physically aggressive, it might get worse at sunset. So I should at least go, and it's called sundowning, and like see if sundowning is a thing that's happening with this person, because I should have that in my treatment plan, right? Good to know, kind of important. Would you have figured that out if no one told you they had Alzheimer's with a scatter plot on your physical aggression data collection? I hope so, right? Like probably. So even when it's important, which in the case of Alzheimer's it is, because there's a number of like organic things happening that we don't not bother treating, but like it's going to change how you set your goals and some stuff. And also like what kind of goals are important to that person, because you don't live forever once you get Alzheimer's. It's not necessarily fast usually, it depends on the type, but it does take a while, but it is something that, eventually you will end up dying of. So it changes some of the goal setting and like targets and like what's meaningful to the person, what makes sense for their life. Absolutely. But also like you would have seen the physical aggression, you would have figured out it's at sundown. And is the intervention going to be different? Not really. I've worked with people with psychosis. I've worked with people that hear voices. I've worked with people that have visual hallucinations. If you ever have someone, by the way, who starts hallucinating like clearly, powerfully, like a lot of hallucinations, and they're a full-grown adult and they have never hallucinated before, send them to get checked for UTI. Like 9 times out of 10, when I had someone who was a full adult, like in their 30s or 40s and 50s, and just started hallucinating, it was always a UTI. If it's an elderly man, definitely get them checked for UTIs if they start hallucinating. It's super common in older men, like in their 70s and 80s. So again, is this stuff good for you to know? Yes, right? Because that's an underlying medical condition. If someone starts hallucinating, what can it be? You need to rule out medical issues, and a UTI can be fatal. It can give you sepsis, and also they don't need a behavior plan, they need antibiotics, right? Because this is not persistent, this is not their baseline, this isn't a behavior they've had in their repertoire for a long time that's been shaped up to be more powerful. Which is all to say, like, sometimes diagnoses are useful, like with hallucinations and UTIs. It's good to know about that and to rule it out. But like once you really get into the nitty-gritty of doing a really excellent functional assessment, doing your observations, doing your interviews, doing an analog assessment if you can, or at least like a trial-based functional analysis. I love those. That was Bob LaRue and Mary Jane Weiss wrote my favorite journal article, and then she was one of my advisors in my PhD program, which is super cool. But that's where you go like do some environmental modifications, like in short trials in their natural environment, so you don't have to have like a whole clinic set up. And it gives very close to the same accuracy as just a 4-condition traditional analog assessment. So I encourage doing all of these things, and if you do them, you would have this information already, right? So like we don't really need the DSM for anything. If someone has a disorder or diagnosis, do look it up, because sometimes there's like tangential things that are associated with the diagnosis that you wouldn't necessarily think to collect data on or to look for that are important. But aside from that, I would say, like, don't get too lost in looking at diagnoses, trying to figure out what diagnosis someone has. Like, it's easy to spend just so much time doing that, and then, like, the benefit to the client or you as a clinician for all of that work will often be zero, or it's a net loss, right? Because you've lost a lot of time and energy that you could have been spending on things that are much more useful. So that's why I don't debate diagnoses. Like, sometimes I will for fun when I'm teaching a psychology class, but again, I went to school to become a licensed mental health counselor. That's what my master's degree was in. So I have education on that, and also I went through all of that school, and I decided, like, you know what, hey, I think ABA is the way to go. I think this is more pragmatic. I think this is the way to help people. And the way I feel that ABA is better at helping most people with most things is because we don't get caught up in these diagnoses. And we don't say, like, this is your box, these are the problems you're going to have, this is where you fit. And by ignoring that, I think ABA is eternally optimistic and beautiful, and helps people that no one else can help. We treat brain injuries. A lot of other fields will say, like, oh, that's organic damage, right? You have brain damage, nothing can be done, and they don't try. Murray Sidman did stimulus equivalents for face blindness on people that had strokes, which is the coolest thing ever, and they were able to, like, remember people's names that went with their faces. And imagine how, like, awesome that is for the person that had the brain injury, that they would be able to, like, see their daughter and be like, oh, you're Mary, right? Instead of, like, not remembering their own family members' faces so that they could, like, say hi and name them or recognize who's in the room with them. Like, we've accomplished amazing things because we don't pay attention to that stuff. That is our strength. So I don't have the energy for it tonight. I'm just going to do a half hour, so a couple more minutes. No one joined tonight, but if you guys end up liking the video, I'll hold it again if you guys would want to attend it, because this is easier than making the Tuesday tip video. But yeah, I would talk about trauma-informed care next week, because that is another one that I love. That's a drum I've been banging for many, many, many years. But I also think the way that we talk about it colloquially as behavior analysts amongst each other can get super weird. And also, it's not this new thing. Like, there's not a lot in trauma-informed care that you wouldn't already be doing if you're doing really good ABA, which I know is controversial. I have trained people in trauma-informed care. I like the sanctuary model. I have a favorite model. Like, I am not poo-pooing trauma-informed care in any way, shape, or form. I think we see these things that are nice, that are important, that are meant to help people who are struggling, and we grab them because we're like, oh, I want to help people. If this helps me help people, I want to learn this new word. I want to learn this new treatment. That's trauma-informed care, right? But there's not anything that we would be looking at, right? That we shouldn't already be looking at if we're doing good work as behavior analysts. And that's why I think our field is, like, just beautiful and eternally optimistic, because we don't get stuck on these things and we don't get caught up in them. So that seems like a really good ending point. I'll post the recording of this to the group, and you guys let me know what you think in the comments. If you want me to do this again, if you prefer something else, if you did want to hear about trauma-informed care, hit me up. And if not, have a wonderful night, and I will see you guys next week.